Okay, ladies and gentlemen, because of the time we will start, we have an interesting session ahead. My co-chairman will probably arrive in a few minutes. That's Javier Escaned from Spain. And the panelists are Dr. Choi, Dr. Johnson, Dr. Kobayashi, Dr. Lim, Dr. Nam, Dr. Park, Dr. Regar, and Dr. Wojakowski. There's a small change in the program. The lecture by Dr. Jung-Min Ahn will be the last lecture of this session because he is still in the cat lab. So you will hear all lectures, but there is a slight change in the sequence. The first lecture is by Nils Johnson. Nils doesn't need to have any introduction, and his talk will be about coronary pressure measurements, and it will be a very interactive talk. Nils.
All right, thank you, Nico. So the way that this works is that I have a series of tracings to show you. And for each one, there's an artifact on it, and we will talk about the tracing, talk about the artifact, and then there's some quizzes at the end, and we'll do as many as we have time for. So sometime in some of these sessions, I ask people to raise their hands. We won't do that here, but if you could just vote in your own mind or think through what you're seeing on this tracing, that's kind of the goal. So this is the first tracing. It's on a scale where you can see the first two heartbeats are a little bit expanded and all of the other ones are compressed together so that you see that the sequence continues to repeat itself. The red tracing, that's the aortic pressure. The green tracing is the coronary. The yellow line is where the FFR selection is. And if you saw this tracing in the cath lab, what is going on and how can you solve it? So this is a problem that's called a whip artifact. And what you have to do is then move the wire back or forth a little bit until it goes away, and I'll show you what it means by that. So the reason that it should catch your eye is that every time systole happens, you'll notice these huge spikes on the coronary pressure. They go up to like 250 millimeters of mercury or something like that. And that's because the pressure sensor is sitting at a very mobile part of the heart artery, and with each heartbeat, it's being thrown against the wall of the blood vessel because there's too much slack or it's in a very mobile section of the vessel. That's why it happens right at the peak of systole. And the solution then is to pull the pressure sensor back or forth so this doesn't happen. That's whip artifact. All right. Here's another example. So there are a whole series of these. That's kind of a little capsulation of what we're going to be doing for this talk. So here's another case. Again, in red is the guide catheter. In green is the coronary pressure wire. The vertical yellow line is where the FFR measurement of 9.3 is. If you saw this tracing in the cath lab, what should you do about it and what is going on? This is a problem that is called damping. And the solution here is to flush the guide catheter to be able to get rid of whatever bubbles or contrast or other materials in there. So to go back to the tracing and explain what's happening, you'll notice a strange thing. That is, the coronary pulse pressure goes from whatever that is, 50 to 100 and something, but the red pressure in the aorta has a narrower pulse pressure, right? The top is not as high and the bottom is not as low. The second thing that's different about the red pressure tracing of the guide catheter is that it no longer has the typical shape of what we think of as aortic pressure tracing. There's no dicrotic notch. There's no a nice gentle fall during diastole. In fact, it looks like a sawtooth. And the reason that happens is that there's material in the guide that's damping the pressure. Eventually, if this went to the extreme, you wouldn't see any phasic tracing anymore. You just see the single average pressure. And this is because you've had some material in the guide catheter that needs to be flushed out. I wanted to spend a few slides talking about what I call Waveforms 101 because once you have these patterns in your mind, you'll be able to quickly see the challenges with some of the tracings that aren't normal. So this is a single heartbeat, and it's in a normal vessel, and you'll notice that there are a few features that it's important to keep your eye on. First is there should be a very nice dicrotic notch, and the second is a very gentle fall during diastole. Now, as a coronary lesion emerges, this is where the circumflex has now been pinched, you can see two things happen. The first is that the coronary pressure loses its dicrotic notch, and the second is that the gradient is larger in diastole. Of course, the aortic pressure doesn't change because the aortic pressure doesn't care what's going on in the coronary artery. Eventually, as this becomes quite extreme, it's almost as if the coronary tracing becomes ventricularized. And again, the aortic pressure should always have the same nice dicrotic notch and gentle fall during diastole. So let's look at another tracing and take those same principles and come back to it. This is a little bit different set of tracings in the sense that it's on a different set of software, but the red is the guide catheter, the blue in this case now is the coronary tracing, and take a look here at what those two curves look like. Now, do those match up with what we saw over here? Again, as you go from mild to moderate to severe disease, you should have this ventricularization. And what's unexpected here is that there's a pressure gradient, but the waveform looks exactly the same in the coronary as it does in the aorta. That's a little strange. Contrast that with the example on the right-hand side. Here, there is about the same gradient between the guide catheter and the coronary artery. However, the shape of the waveform in the coronary artery is different. Now you've lost the dicrotic notch, and now there is almost that ventricularization again. The waveform on the left is an example of drift, and this is because you can know that if you had a gradient that big, you should have a difference in the morphologies of the lesions, where on the right-hand side, that's a real pressure gradient because the waveform changes shape. And you know that because we just went through those series of tracings as lesions get worse. Drift, of course, something that happens potentially on the wires, good to check for it, but a simple clue here on this side is when you have a big gradient with the same morphology, that can't happen with the way coronary physiology works. All right, let's try our hand at one or two more pressure tracings, and then I think my time will be up. So here's another example. Take a look at it. Red is the guide catheter. Green is the coronary pressure tracing. The vertical line is where the computer has made its measurement to 0.9. If you saw this on the screen, what's going on, and what should you do about it? Well, this is an example of ventricularization, and what's happened here is that the guide catheter has become too far engaged into the coronary artery. You'll notice as you come back to the pressure tracings that the aortic signal has lost its dicrotic notch. It no longer has a nice gentle fall during diastole. In fact, it looks very much like the ventricular waveform. This is an example of what can happen in terms of the measurements. It's one of the few times where you can get a false negative FFR. So this was a case with an LAD that was published. You can see the guide catheter and the mid lesion. At the top, they made the measurements after an intracoronary injection, and probably what happened is the EBU, for example, guide that they were using slid up into the left main. When you take a look at the hyperemic waveforms over here on the side, you'll notice that the aortic waveform doesn't have a dicrotic notch, looks very ventricularized. They realized, though, that this was a problem. They did the measurements again, but this time they were more careful. They unseated the guide a little bit, and now take a look at the redone measurements on the bottom. Actually, the coronary measurements have the same pressure, 64 and 64, but what's happened is the aortic pressure has increased from 71 to 87 because the guide has been properly unseated and there's no more ventricularization. And so the FFR apparently was 0.90, but it was actually 7.3. And so this is an example of a false negative FFR when people were not paying attention to the ventricularization problem. I'll just do one last tracing to finish, and then I'll have shown you, I think, kind of the 5 or 6 big artifacts. So last one. Again, red is the guide catheter, green is the coronary artery, the vertical yellow line is where the computer has made the selection for an FFR of 7.3. If you saw this in the lab, what's the problem and how should you solve it? The challenge here is that the computer, because it's not very smart, artificial stupidity, you might call it, has simply made that yellow line at the point where there's the lowest ratio. But you'll notice that this must have been a tracing made using an intracoronary injection, say, of adenosine and perpaverin, because for those first 4 or 5 beats, there's no valid aortic pressure tracing. And this was just something that the computer happened to latch onto and had made the wrong choice. And it's a reminder then that whenever the computer says this is where the best FFR is, it's important to look at the pressure tracings for that segment to make sure that they're good pressure measurements, valid pressure measurements, to get the right answers. All right, those are the top 5 artifacts. If you take those with you, you'll be experts and you'll get great data and be able to use it to make good decisions no matter what you're doing. Thank you.
Thank you, Dr. Johnson. It is very interesting, and it is clear that pressure measurement is very simple to perform. However, you should be aware of this kind of pitfalls. And the big common message, in fact, is that you should never only look to the numbers on the screen, but look at the tracings. Then you will notice what is wrong, and you will notice if your observations are indeed reliable or artificial. we will continue with the next presentation. And as I mentioned, the presentation by Dr. Ahn. Oh, he is still here. I got a message that you was later, that you were stuck in the cat lab, but you are here. So go ahead, Jung-Min.
So,
Dr. Ahn, of course, needs little introduction. He's one of the organizers of this fantastic course, and he is running all the day between the COAX Center and the Asan Hospital.
thank you, Nico. My topic is contrasting prognostic value of discordant between FFR and non-hyperemic pressure ratios. Non-hyperemic pressure ratio is a non-hyperemic alternative to the FFR measurement, but sometimes, not always, the binary result of FFR and non-hyperemic pressure ratio is not concordant. For example, non-hyperemic pressure ratio 0.95 sometimes is final FFR value is above the 0.80, below the 0.80, the final FFR after hyperemia below the 0.80. But this is concordant. But sometimes the negative non-hyperemic pressure ratio sometimes below the 0.80. Sometimes the positive non-hyperemic pressure ratio is above the 0.80. This is discordant. This 61 male effort-related chest pain, added FFR is 0.95, but final FFR is 0.75, huge pressure drop. Another case, 83-year-old male with severe AS, IFR was 0.84 positive, but FFR was 0.85. So this is an opposite case. So it happens how much? So incidence is based on the previous literatures, the 13.7, 13, or up to 20%. The FFR registry show that the diagnosis accuracy is 81%. Our registry data accuracy is 82, so 19% discordant. So instance of discordant between non-hyperemic pressure ratio and a final FFR was 15 to 20%. So what is the underlying mechanism? Previously, some doctors evaluated the physiology characteristic of discordant lesion. FFR positive discordant show that the very high CFR. IFR positive discordant show that the low FFR. Similar finding applied to the resistance reserve ratio. So in addition, what is the anatomical characteristics? FFR positive discordant more frequently associated with adverse plaque characteristics. In addition, more focal lesion. IFR positive discordant is associated with diffuse lesion and less adverse plaque characteristics. And what is the clinical characteristics? So FFR positive discordant is associated with the high CFR characteristics, so young, male, non-diabetics, and proximal location. But IFR positive, non-hyperemic pressure positive, positive discordant is associated with old age, female, diabetes, kidney disease. So this is a summary of underlying mechanism. Non-hyperemic pressure ratio positive discordant is associated with low CFR, coronary physiology, diffuse disease, less adverse plaque characteristic, dislocation, and old age female diabetes kidney disease. FFR positive discordant is associated with the super high CFR, focal disease, more adverse plaque characteristics, proximal location, tight lesion, complex lesion, younger age, male. So I like to say that non-hyperemic pressure ratio positive discordant would be the unhealthy vascular status, and FFR positive discordant is associated with more complex coronary atherosclerosis. Then what is the prognosis? So far, very limited data. The only two data I found that discordant lesion is only 72, 63. So very limited statistical power. There is no statistical difference between FFR positive discordant and non-hyperemic ratio positive discordant. Recently, J-Pride registry enrolled 4,000 lesions in 3,000 patients. They show that only FFR positive discordant is associated with lower event rate compared when you put the stent. But FFR negative discordant is not. So this study suggested that the FFR would be the revascularization strategy should be based on the FFR value. But even in this study, they did not show the difference, prognostic difference between the FFR positive discordant and non-hypertrophic pressure positive discordant. So last 10 years, we enrolled the FFR registry. So around 10,000 patients, we measured the resting PDPA instead of IFR and final FFR. We grouped the 4 groups. Group 2 and group 3 is, group 2 is non-hypertrophic pressure ratio positive discordant. Group 3 is FFR positive discordant. Incidence was 17%. So we evaluated in the default region, we separated two clinical outcomes, target vessel failure, including target vessel MI, target vessel revascularization as lesion level analysis, and death from any cause as patient level analysis. This is very interesting findings. Target vessel failure, 4 groups, this is concordant negative, this is FFR positive, concordant positive. FFR positive discordant lesion show that the very high target vessel failure rate in default lesion. And FFR compared with the FFR, PDPA positive discordant. When you look at only 2 lesions, compare with the PDPA positive discordant, FFR positive discordant significantly increase the risk of target vessel failure. So compare with the revascularization and deferral in discordant region, resting PDPA positive discordant was not associated with the benefit of revascularization. Only FFR positive discordant region is associated with the benefit of revascularization. How about the death from any cause? Totally different from the target vessel failure. PDPA positive discordant show that the highest mortality rate. Look at the 2 discordant. FFR positive discordant is associated with a very low mortality, but PDPA positive discordant is associated with a very high mortality. Even FFR positive discordant show that the better survivor compared with the concordant negative patient. So every subgroup show that similar outcomes. This is my summary. These multicenter prospective studies aim to evaluate clinical outcomes in default lesion with a discordant between binary resting PDPA and FFR using target vessel failure as a lesion-specific outcomes and death from any cause as a patient-level analysis. Among discordant lesion, target vessel failure occurred more frequently in lesion is positive FFR discordant, whereas death from any cause occurred more frequently in lesions with positive resting PDPA discordant, highlighting the contrasting prognostic value of these indices. Therefore, these findings suggest that through the complementary evaluation of both index resting and hyperemic index, clinical decision regarding revascularization should primarily rely on FFR, and the identification of lesions with the positive resting PDPA discordance may warrant surveillance of patient overall vascular health. Thank you for your attention.
Thank you, Jung-Min. We will further have the opportunity to discuss this during the panel discussion. We first continue with the next lecture by Dr. Fearon from Stanford about the FAME3 study. Dr. Fearon was the principal investigator of the FAME3 study, and he will give us now a kind of overview, I think, about a number of sub-studies and about the recently published 5-year follow-up.
Thank you, Nico. Just as a reminder, for those who aren't familiar, FAME3 is a study comparing patients with 3-vessel disease not involving the left main, FFR-guided PCI with current generation DES with CABG. Many of you are probably aware of the primary endpoint, which was the composite of death, stroke, MI, or repeat revascularization at 1 year. And PCI did not meet the criterion for non-inferiority, as you see here. However, when we compare FAME-3 to the syntax trial, which had a very similar or basically identical primary endpoint at 1 year, you see that the outcomes in both the PCI and the CABG arm are more favorable compared to syntax, and the difference between PCI and CABG has narrowed significantly. We can further refine our ability to identify patients who might do better or worse with PCI or CABG by looking at some sub-studies. One is based on the syntax score, and you see that about a third of patients in FAME-3 had a low syntax score and 2/3 had intermediate or high. Now, of course, there's probably some patients in this intermediate or high group that had reasonable outcomes with PCI, and the question is, how can we identify them? And one way of doing that is by incorporating the functional syntax score, where you take into account the FFR information, and if FFR was negative, you subtract that vessel from the syntax score. And you see that you can identify 50% of the population that had a low functional syntax score. And the reason this is relevant is because if you look at the 1 year outcomes of death, MI, stroke, or repeat revasc, in the low functional syntax score, they're identical to the CABG group. Now, we followed patients out to 3 years, and we had a key secondary endpoint that was pre-specified, which just focused on hard endpoints, death, stroke, or MI. And you see there was no significant difference at 3 years, although there was a trend favoring CABG. This was due to a difference in MI. You see that death was identical between the two groups, and stroke slightly favored PCI. When we apply the functional syntax score to the 3 year outcomes, we again see that in the low functional syntax group, so half the patients, they have identical outcomes with respect to death, stroke, or MI at 3 years, whereas it's in the high group, the CABG patients fare better. Now, what other subgroups can we look at? Well, we looked at sex, and we see here that women, shown in red solid and red dashed lines, had similar outcomes whether or not they had PCI or CABG, and they were also similar to men who had PCI. And the one group who seemed to do better than the other three were men who were randomized to CABG. When we look at diabetes, again, there's no statistical interaction between the groups because both CABG patients with diabetes and PCI patients with diabetes fared worse than the non-diabetics, but you do see a clear difference here in outcomes where PCI with diabetics seem to do the worst. We also looked at CTO patients, and this is interesting. Patients who had CTO, whether they had PCI or CABG, had lower 3 year event rates compared to those without CTO, or at least numerically lower. When you just focus on the PCI group, so patients who had PCI with no CTO, shown in red here, compared to patients who had PCI with a CTO, had the CTO group actually did better. And when you drill down on this, it appears to be related to lower MI rates as well as lower repeat revascularization rates in the CTO group. And the way we explain this is that perhaps it's because those patients have fewer vessels that could actually have an MI or need a repeat revasc. Another important subgroup are ACS patients, acute coronary syndrome. 40% of the population in FAME-3 presented with an ACS, and those are shown here on the left in red, and you see that there was no difference in outcomes at 3 years between PCI and CABG in the ACS patients. Interestingly, in the chronic patients, you see that CABG patients fare better than PCI group. We've also looked at quality of life and cost effectiveness. This is 3 year data, we plan to present 5-year data, hopefully at ESC. On the 3-year data, you see that there's no difference in the EQ5D summary index between the two groups. When you calculate quality of adjusted life years, there's a slight numerical advantage to PCI over CABG. And when we look at costs, not surprisingly, costs are much lower in PCI at baseline, and there's a slight catch-up, but still there remains a very highly significant difference in costs at 3 years. So because of this, PCI in 91% of the replications on the bootstrap analysis had both lower costs and higher quality adjusted life years compared on analysis. In addition, if you look at the cost effectiveness ratio using the 50,000 per quality adjusted life year cut point, 100% met that, so strongly favoring PCI. So we can summarize these sub-studies by looking at which factors favor PCI, in which cases are PCI and CABG somewhat equivalent, and which ones favor CABG. And I didn't show the low syntax score data, but those favored PCI. The high and intermediate functional or syntax score you saw favored CABG. Low functional syntax score have similar outcomes, whereas high functional syntax score favor CABG. Women have similar outcomes, whereas men seem to do better with CABG. No diabetes and diabetes, ACS and CCS. Quality of life was similar, and costs were lower after PCI. So what's next with FAME3? Well, a little bit later this afternoon, I'll present the 5-year follow-up of the FAME3 trial. Thank you for your attention.
Thank you very much, Bill. We will come back to this, and we will start with the discussion. And I take my advantage as a chairman to put the first question to Jung-Min. Where is Jung-Min? Oh.
He left. I saw him walk out.
He left. Okay, then I will just keep it short. There is, of course, you can say there is a phenotype with positive IFR and negative FFR, but the more obvious reason for this discordancy is the fact that many patients in a cath lab are not at rest. So if you measure a value of IFR of, let's say, 0.87, it can be a patient who is excited and who has a resting blood flow which is twice as high as normal resting blood flow. And then it is logical that that value is lower, so it is not a true discordance, but an apparent discordance. The other point is, and that's why it's a pity that he already left this, that if you look at the defined flare and the sweetheart studies, these seem to be large studies with 1,500 patients each and 2,000 lesions each. But these studies were primarily anatomic studies because in the defined flare and sweetheart, only 50% of the patients had any physiologic measurements. All the other lesions were based upon the angiogram. And if you count that out of the 1,000 lesions which has physiology, there were 20% discordant, it means that 200 lesions had either FFR or IFR. They never had both of them. So the power of the study was based in a low-risk population on 2 times 100 lesions. In contrast, the J-PRIDE, which has been published recently, was 4,000 lesions, and all of these had both IFR and FFR. So the J-PRIDE had 800 discordant lesions with both measurements. That means that the power of the J-PRIDE was 4 times as high as the power of defined flare and sweetheart together. In J-PRIDE study, it was found that patients in whom the treatment was based upon IFR had a twice time higher event rate than in patients with FFR guidance. And even in defined flare and sweetheart, the mortality rate after 2 and even more after 5 years was higher in the patients based upon IFR. So my question to Jung-Min would have been how we could defend with dry eyes that IFR should be used instead of FFR. This is recognized by the American guidelines, not by the European guidelines. Apart from this, we cannot discuss with him, so there's a little bit of pity. So the discussion is open for the lecture of Nils and the lecture of Bill.
Maybe, Bill, if I could ask you, one of the other great sub-studies I really liked, I think that you guys talked about in FAME3 was this definition of periprocedural myocardial infarction. We'll often see much higher enzymes after bypass surgery than after PCI. Maybe just tell us a little bit about what you've seen in FAME3, since that was something that you had to pick some definitions, and I know different ones exist out in the world.
Yeah, thanks, Nils. So we thought carefully about this because the whole Excel controversy had occurred, and we wanted to be sure that we had a fair and even playing field. And so what we decided to do was choose procedural MI definition that was a type 5 based on the universal definition for CABG. So we used this, it was a pretty strict definition, and it was the same in both arms. So that way the clinical events committee could adjudicate while remaining blinded to which treatment arm. And because of that, the procedural MI rate was low, and it was similar between the two groups. Now, as you mentioned, with bypass surgery, you can get enzyme elevation, and the SCAI definition which has a more liberal definition for MI, includes these and has been shown to be prognostically important. There's higher death rates at long term in patients who have a SCAI procedural MI. So we did a sort of a secondary analysis where we used the SCAI definition, and that actually completely changes the interpretation of the trial, because then the MI rates, procedural MI rates, strongly favor PCI, and even at 1 year, we would have met non-inferiority, and then also at 3 years, and as you'll hear later today, at 5 years, the event rates would have been lower with PCI. So it's important to get into the weeds when you're thinking about trials and trial design and think about these different definitions, because they can have an effect on how you interpret studies. But I wanted to get back to Nico's point and ask you, actually, Nils, or anyone else who wants to comment. The defined flare showed the higher mortality in the IFR group at long-term follow-up, and it tended to occur in the patients who were revascularized in the IFR arm. And the argument is, oh, well, then it must be chance, because if it was in the deferral arm, then IFR was missing lesions that should have been treated, and that's why they had. But since it was in the treatment arm, it must be just play of chance. But you and Carlos and others showed in the PPG global study that if you treat diffuse disease, you can have higher procedural event rates and maybe, who knows, worse long-term outcomes. We'll have to see. And since IFR tends to be discordant in patients with diffuse disease, could that be the link or the explanation for why the IFR group had higher mortality?
I'll leave it up to others on the panel. Perhaps I don't want to monopolize things. I'll look down the way here to get other people's viewpoints on the interesting hypothesis. Oh, going to make me say something here. We'll get Carlos up to tell us about PPG and diffuse disease.
So I'm just going to kind of also give some information about. I have thought about that you just mentioned. What we saw in PPG Global was that we did a very detailed analysis of the procedural MI, and there were two things that kind of pop up from the data. The first one Nils mentioned: when you treat diffuse disease, you put longer stents, and then you get more side branch occluded. So that was the first mechanism, kind of justifying the higher incidence of procedural MI, double the incidence. The second one was funny. The amount of 70 times troponin, a standalone marker for periprocedural MI, was also 2 times higher in diffuse disease. We don't know why that happened. There is no side branch. We counted the side branch one by one, and so we did a lot of detailed work on that. But we've just found that when you treat diffuse disease, there is a very, very high elevation of troponin in cases. This is double that what happened in focal disease. So if there is a link with mortality, well, there is a link between periprocedural MI and mortality. If that is what happened in defined flare, I don't know, but that's a bit more information of what you just mentioned.
There is another concern in these studies, I think, and that's the following, and that is that the false negative IFRs were systematically removed from the analysis. If you had a patient in the defined flare study with, let's say, a proximal area D lesion of 50%, then there was no physiologic measurement performed. It was just stented immediately. But this is typically the type of lesions where you find a negative IFR and a positive FFR. So this patient was analyzed as if he had had an IFR measurement, although it wasn't performed actually. And 50%, no measurement was performed. So this patient was counted as a true positive IFR instead of a false negative IFR. And this is something which was quite often in both the defined flare and the sweetheart study. It is difficult to find that out if you are reading the paper. I had to read it at least 7 times before I found it out. But what you should realize is that in 50% of the patients, nothing was measured. No FFR, no IFR. First, there was an anatomic assessment, and only if the operator thought, well, this lesion is less than 50%, then he could measure if he liked. So this really gives a little bit skewed interpretation of the data. To continue with the talk of Bill. Bill, you did an excellent presentation, and I mentioned to you this morning. When you gave the presentation, it was at TCT, I think, or at ACC, the New Breaking Trial lecture. We had a broadcasting of that to our hospital in Eindhoven, and our staff and the residents and the cardiac surgeons were all present. And when you finished by concluding that still PCI with FFR and with modern stents was inferior to cabbage, one of the surgeons came to me and said, Nico, are you disappointed? I said, no, I'm not disappointed at all. Compare these data with Syntox. What you see is that the event rate in the PCI group and in the cabbage group is both only is 40% lower than in the Syntox study. And the results with PCI in the FAME3 are lower than the results of cabbage in the Syntox study. So I said, both of us won. We have improved PCI a lot by FFR and modern stents, but you also did a better job. So I think that's the quintessence of medicine. By having this kind of competition, both players improve their skills. And I think this is one of the real good messages of FAME3.
Yeah, we were really surprised, as you know, how well the cabbage arm did. I think if we had expected cabbage arm to have a 12% event rate like they did in Syntax, because, you know, it's hard to think of a major breakthrough in cabbage surgery over the past decade. But yet the cabbage arm went from a 12% event rate to 6.9%. So they really did better. And I think that is because we've learned a lot about patient selection probably. I think their techniques for avoiding strokes and other complications peri-procedurally have improved. So all of that led to, and medical therapy, I should say too, in FAME3, about 90% or more of patients were on statins. If you look at Syntax, it was only around 70%. There are more people on, you know, blood pressure, beta blocker, ACE inhibitor, ARB. So anyway, I think there are a few different things, but you're right. It's good news for everyone, and patients especially.
Thank you.
I'd like to ask
Anybody else from the panel? Yes, please.
Yeah. Okay, I have one question to Dr. Beer. Yeah, so about the, did you check the first PCI FFR in FAME3 study? So whether, if do not the first PCI FFR, but you can check the Angio-FFR also. So I wonder that nowadays we believe that post PCI evaluation of physiology. So if you are optimized physiology guided PCI, that can be better outcome compared to sub-optimized treatment. So did you analyze that?
Great question, Chang-Wook. And I didn't have enough time, but Zsolt Puroth did publish a sub-study looking at post-PCI FFR. About 60% of patients had a post-PCI FFR measurement. We encouraged it in the protocol, but didn't mandate it. And yes, I mean, it's, you know, it's not a randomized study, so it's, or a sub-study, so it's not really truly a fair comparison. But if you looked at the patients that had post-PCI FFR, they had better outcomes compared to the ones that didn't, for what it's worth.
So, Bill, I'm going to address that point later in my presentation, but before you leave, one of the major findings of the Syntax 1 trial was that there was a huge variability in outcomes according to the hospitals that the patients were treated in. That is almost invalidating the trial. If you see the plot what happened, you have sites with 0% event rate in surgery and 40% event rate in PCI. And the other hospitals completely the opposite. One of the benefits of imaging and physiology is that you have a better decision-making, you reduce variability in decision-making because you're following a number that everybody should follow, and that's basically the protocol. Did you observe a difference, or was there a correlation at least between the outcomes in the two arms when you look at specific hospitals?
Yeah, I remember that slide that you're talking about where they have like the balls showing like surgery. Some patients like, you don't want to have surgery at that hospital. But we haven't looked at it at a hospital level. We did look at it at a sort of geographic level, like Western Europe, Eastern Europe, North America, Asia, but, and there wasn't any interaction there. But yeah, we don't have or haven't done the data yet based on hospitals.
Okay, thank you.
Oh, please, one more question.
Sorry, yes, go ahead.
Thank you. Thank you for a nice lecture for phase 3 study results. You can show the primary endpoint just for ischemic events. So relatively in PCI group, persisted to depth. So I think long-term result is safety result is so important. So you analyze is for the net clinical benefit, including bleeding events. Do you have any results?
Yeah, it's a great question. Historically, repeat revascularization has been included in composite endpoint, but you could argue that things like major bleeding or repeat hospitalization or kidney issues or arrhythmias like atrial fibrillation are just as important. And actually, studies have shown that people who get AFib after CABG have worse mortality compared to those who don't. We did look at that in the one-year outcome, and those four things, bleeding, kidney injury, arrhythmia, and repeat hospitalization were all significantly higher after CABG. So again, you choose your endpoint. The reason we chose the endpoint we did was because we wanted to have everything the same as syntax except the FFR and the new stents and see how that changed things.
Okay, we have to continue. The next speaker will be Dr. Matsuo. Long ago, I was in Japan, and I met a couple of fellows or young cardiologists, and they all wanted to show a case with FFR to me. And there was one person, and that was Dr. Matsuo, who showed me a case. He said, this is one of the first cases I did. And I said, this is one of the most beautiful cases I've ever seen. And I stimulated you to publish that then.
Thank you very much for the kind introduction. It's my great pleasure to be presenting about the CT-FFR and Angio-FFR. Do we really need the wire? It's a very attractive question I have. This is a slide showing the disadvantage of wire-based functional assessment, invasiveness, and duration, medical cost, and technical expertise. They all require the procedure of the FFR. So this is the slides showing the development of the functional coronary angiography. So our algorithm, we have several indexes now in the clinical practice. mu-QFR, QFR, FFR angio, and VFFR. So algorithm for the calculation of this virtual FFR is different slightly. So CFD-based functional coronary angiography is mu-FR, QFR, and VFFR. These are CFD-based FCA. On the other hand, FFR angio is a vessel resistance-based functional coronary angiography. Furthermore, now we can use the AutoCAS FFR, which is completely AI-determined FFR. So this is a table showing the difference of the QFR, VFFR, FFR angio, and mu-QFR. you know, the requirement of the angioprojection is completely different. Mu-QFR requires only one projection, and VFFR, QFR requires 2 projections, and FFR angio requires 3 projections for the analysis. So boundary conditions required for the assessment is aortic pressure is required, VFFR and FFR angio, and the frame counting required in QFR and mu-QFR. Also, it is all automatically now acquired. And as you know, the time to computation, it is a good, very important factors. Mu-QFR is the shortest for the analysis, 1.12 minutes, and QFR and FFR is around 4 minutes. However, evidence is clearly, the number of evidence is much higher in the QFR, and the diagnostic accuracy is all of these indexes is quite good. And the proposed clinical application of functional coronary CT angiography and functional coronary angiography is here. PCI, as for the PCI in CCS, physiological lesion assessment before PCI, which means indication of the PCI can be determined by this, and the PCI planning with pullback curve and the PCI optimization before finishing procedures. In the ACS, non-culprit lesion assessment, we expect a lot to the dysfunctional indexes. And as for the multi-vessel disease, it takes time for assessing multi-vessel by the wire-based assessment. So functional coronary angiography may have some beneficial in this point. Let me show the state of the Japan about the functional coronary angio, FFR angio. Now it's 224 institutions using the FFR angio. As you can see, the number of the institutions increased. As for the QFR, now 112 institutions are using the FFR angio for 1 year. Let me show one case. This is a tandem region, already tandem region, hip is melt, stable angina. So the CT angiography shows a very beautiful pictures, so plaque distribution as well as physiological informations. So you can see this pressure gradient is very high as shown in this. And by using the FFR CT planner, we can plan the PCI, which part of the lesions should be covered with a stent to get the maximal obtainable effect physiologically. You can see only the one stent of proximal and distal doesn't get a good result after the PCI. And after 2 stenting here, you can see the very beautiful result. FFR will coming to the 0.86. How about the functional coronary angiography? This is the same patient. You can see the beautiful pullback curve as shown like this to step up here and here. And if we put a stent in the proximal part of the lesion, you can see FFR is going up to 7.4. And if we put the stent to the distal part of the lesion, we can see the 0.75 and 0.9. So we need the 2 stent here. And you can see by the QFR, you can see the good result as well. This is a QFR result. If distal region is here, and if we treat both regions, we can get the FFR, QFR 0.98. It's the same. So all of the functional coronary angiography requires 2 stents in this case, and wire-based FFR 2 stent makes a good result as well. And you can see the FIRE trial, which is a multi-center randomized trial comparing the culprit-only lesion PCI and physiologically complete revascularization. You can see that from the culprit-only lesion PCI, the FFR QFR in the non-culprit region is significantly higher event rate in the higher ischemia positive region and compared to the negative regions. And in this study, physiology-guided PCI is based on the QFR or wire-based guidance. Also, this is not a randomized control trial. You can see the good result with the QFR guide decision making. So this is a Kaplan-Meier curve as well here. Also, phase 3 Europe trial, this is a prospective randomized trial, so comparing the QFR based diagnostic strategy versus FFR guide diagnostic strategy. We can't demonstrate the non-inferiority compared with FFR angio. So results are still controversial. So we need to see a future result of the prospective randomized trial comparing the QFR guidance versus the usual care, which is a Pioneer 4 trial. It's now will be soon coming. And as for the FFR angio provision study, which is randomization of 200 cases each for FFR guided arm and FFR angio guided arm. Final result, including 1-year clinical outcome, will be presented at Europe PCL 2025. Furthermore, the All-Rise trial enrolling 1,924 patients, one-to-one randomization to the FFR angio guided treatment arm and pressure wire guided treatment arm. This enrollment has finished end of last year. Therefore, the clinical outcome data will be coming in these trials. So take-home message is here. CT-derived FFR and angio-derived FFR are promising physiological assessment technologies. This next generation functional vessel assessment enables seamless treatment decision-making before, during, and after revascularization in various clinical subsets. Also, phase 3 Europe failed to show the non-inferiority of QFR guide strategy compared with the wire-based FFR. Upcoming prospective randomized trial comparing FCA-based decision-making and wire-based decision-making will give us an answer whether non-wire-based technology will be able to replace wire-based physiological assessment. Thank you very much for your attention.
Thank you, Dr. Matsuo. We will continue. We will have the discussion later on with another innovative index by Carlos Collet from Aals in Belgium. It is the pressure pullback gradient to personalize PCI. And it will talk about the PPG global registry, which has shortly be completed, I think.
Thank you, Nico. And indeed, I think we have moved from facing the use of physiology, where it was used to determine lesion significance, which is a diagnostic tool as you developed with Bernard, Nico. And we have moved this tool to a planning tool. And by doing that, we have just realized that physiology has the potential to predict what will happen. And this is completely new. And what I'm going to show is the first data. This is a 1-year follow-up of patients, including PPG Global. We'll explain you all about that. These are my disclosures. And we start by the fact that we recently understood that the effectiveness of PCI, so the ability of PCI to improve flow, depends on the pattern of disease. And the pattern of disease can be looked at using a pullback curve, and this can be quantified using the PPG. And before we published this study, we knew that there was some initial data showing that this improvement in flow had a consequence that was improvement or not in patient symptoms. So we're kind of putting the dots together. So this is how it works. You do a pullback curve, you get this number. This is fairly automatic. It's a mathematical calculation. It takes seconds. High PPG is focal disease, low PPG is diffuse disease. And these are the main results of the study published a year ago in Circulation, basically showing that if you have focal disease, all these patients have positive FFR, by the way, but if you have focal disease, you gain more FFR, so the delta FFR is higher, and the degree of revascularization is also higher. If it's blue, it's more than 88. If it's red, it's less than 88. That's the cutoff also confirmed in the FAME-3 analysis. Now, in this study, we tried to understand what was the impact of PPG in the symptoms as reported by the patients, and to explore what happened when we did all the treatment strategies other than PCI in patients with diffuse disease. So this was an investigator-initiated trial done by us, coordinated by us in Belgium. All the patients had a positive FFR, and we excluded patients with major comorbidities or other situations where measuring FFR many times was cumbersome. The protocol was very simple: FFR at the beginning, with PPG. This was installed in all the sites. This is how the console looks. And after that, when you finish the PCI, you measure post-PCI FFR. Now, we let the investigators decide what they will do, because we didn't have any clear idea whether PPG at that time would work. So basically, they could decide on, yeah, I'm going to do PCI irrespective of the PPG. I'm going to do surgery or medical therapy. Good. The patient symptoms were measured using the Seattle Angina Questionnaire in all, of course, the local languages. All the data was analyzed by a core lab. And going back to the point by Bill before, we used the fourth universal definition, and all the events were adjudicated by an independent committee. So this is the flowchart of the study. We had 1,004 patients that were screened. We ended up with 993 patients included, and I'm just showing here that from this, 640 reported to be symptomatic. This is not the physician saying that the patient is symptomatic. This is the patient saying that they are symptomatic according to the questionnaire. If we think about what happened with the patients, this is the treatment strategy. So basically, all of the patients, or 96% of those with focal disease, underwent PCI, but look what happened. Almost 26% of the patients with diffuse disease, this divided by the median of PPG, were treated with a different approach, being a medical therapy in 60% and surgery in 10% of the cases. When we understand the baseline characteristics, so the question is, can we differentiate the patients based on their baseline characteristic? The answer is no, we cannot. They look all the same. They have the same age, the same comorbidities. But when we think about the procedural characteristics, we do. So diffuse disease is more prevalent in the LAD. And then you see here as well that when you do PCI, the patients with low PPG or diffuse pressure losses, of course, they receive more stents, longer stents, and smaller stents, which, of course, makes sense. Now, we already reported this value, is the fact that the post-PCI FFR was higher when you treat focal disease, and the delta FFR was more than double in cases with focal disease compared to diffuse disease. Now, these are the main outcomes. These are the Seattle Angina Questionnaire at baseline. There were no difference in terms of angina frequency. And then when we look at the same data at 1 year follow-up, this is what we found. Patients with focal disease, they felt better and reported significantly less angina compared to those with diffuse disease. Now, what was also interesting to see, that there was kind of a dose-response effect. When we look at the PPG in these beans, and you see the delta or the change in the Seattle Angina Questionnaire score in the vertical axis, you see here that the higher the PPG, so the higher or the more focal the disease, the better the improvement in the patients. This is, again, breaking down the groups into focal or diffuse CAD, and you see here that the patients with focal disease, they had a higher proportion of being free from angina, and they reported less degrees of angina compared to those with diffuse disease that were more symptomatic after the procedure. Now, when we start looking at the outcomes, now, not in the focal or diffuse disease, but stratified for what was done. Was PCI in focal, PCI in diffuse, surgery or medical therapy, and we're going to be looking here at the Seattle Angina score at 1 year, so how the patient fell after 1 year of treatment. This is what we found. I like the words that Nils uses. The patients with focal disease are the winners. So these are the guys that feel the better. And then you see that PCI in diffuse disease, PCI or surgery, they have more or less the same angina frequency. And I have to say that the patients treated medically reported higher level of angina compared to those that were revascularized. Now, when we look at outcomes, and this is TVF, with the classical definition, you see it on the bottom of the slide, you see in this Kaplan-Meier plot that patients with diffuse disease treated with PCI had the highest event rate, and this was entirely driven by a higher incidence of periposteal MI, as we discussed previously in this session. And you see that this is followed by the patients treated with focal disease. And what was reassuring was the fact that patients with diffuse disease differ from PCI, or this orange line, had a very, very low event rate with a couple of revascularizations occurred at the end of 1 year. When we look at the same plot, but now excluding all the periposteal MIs, we see actually no difference in the outcomes in this different group and categories. So I think it's important when we analyze this data. This was, again, the first large scale study with PPG. We didn't, of course, randomize, it was observational, but we used a Seattle Angina score only 2 times. We understood in the meantime there are a number of limitations of using these scores. We didn't have any app or any other alternative way when we started the study. We did not provide the physicians with a cutoff, which we're going to do in the next trial. In this trial, we just explore what happened at different levels of PPG. So basically, every physician decided by himself or herself what to do with that specific pattern of disease. And we powered the study not for clinical outcomes. We powered the study to assess the capacity of PPG to predict post-CT-FFR. So we would need to, of course, have more patients to look at clinical outcomes. Nevertheless, I think it's fair to conclude that if you have a patient that has focal disease by physiology, and this is not anatomy, this is physiology, quantified by a high PPG, it is very, very likely that that patient will be completely asymptomatic after you perform the PCI. PPG was independently associated with angina relief, and it was independent of other clinical factors, including FFR, so it provides another information to FFR. And I think that it's also interesting, hypothesis generating, the fact that we did not see any difference in endpoints between the different treatment modalities. Therefore, I think we can conclude that this PPG Global, this is a 1-year follow-up, highlight the utility of PPG in predicting patient outcomes by predicting the benefit of revascularization. And this is a complete novel application of physiology that, in my opinion, is more relevant than ever before. I cannot conclude this presentation without thanking all the sites. I think the contribution from Japan was huge. Professor Matsuo was the second recruiter in the trial. So I think we're very grateful to all the colleagues in Japan and in different geographies that contributed to the study. Thank you very much for your attention.
Thank you, Dr. Colette. Then we will continue with the last presentation by Dr. Shengxian Tu. I hope I pronounced the name well. And he will talk about the computational coronary physiology.
Thank you, Chairman. Dear Chairman, dear colleagues, it's my privilege to be here. My name is Shengxian. I come from Shanghai. This is my disclosure. So this is a study we published last year. We pull out all the data. As you can see that without FFR guidance, about 1/3 of the physiology significant lesion would receive PCI without the FFR guidance. So in order to improve this, I think wear-based FFR is not enough because so many years the adoption rate does not increase. So it's my belief that the imaging-based physiology or computational physiology might help to expand the adoption of physiology. So the principle has been explained in this review paper, using imaging and create the model and using the formula to solve the fluid dynamic equation, either by CFD or simplified fluid dynamic equation. You get the pressure drop and the FFR. And among them, these are the technology we developed from our lab, CT-QFR, QFR, and the second generation mu-QFR, and the OCT-based OFR and UFR. And this has been also stated in the consensus paper by this paper. As you can see, we provide all this imaging-based physiology. I have to clarify that the name of the QFR actually outside China has been changed to mu-FR. So this is a bit confusing. So when you see the paper from China, QFR actually is the same as mu-FR outside China, but the QFR from outside China is no longer affiliated to our group. So let me explain the difference between the first and second generation. The first generation, only single vessel, we are reconstructed. So in the calculation, we have to get the reference lumen without a side branch, you can only assume linear tapering. So this could be a limitation in assessing the bifurcation lesion. And in the second generation, we incorporate the side branch, as you can see here, in the computation of the FFR. So we reconstructed this more like step-down reference diameter, which is more accurate representation of the reference vessel. And second is that we're using artificial intelligence to automate the analysis. So the analysis time has been reduced from 5 minutes to 1 minute. And third is that we can calculate single projection. And let me show you a video showing that in real-time recording how fast this can be done. So the operator can only need to select the projection, and the software will do it automatically, all the other steps for you. So select the best frame for analysis, and then the linear lumen and calculate the pressure drop. As you can see, this has been done here. Here the lesion caused the pressure drop, and the mu-FFR is 0.72. So we compare the single view with two view, and in this study we saw that actually the single view is as good as the two view solution. And one of the reasons is that theoretically, if you add the second view, it will be better. However, in practice, the second view is less optimal as the first view. So sometimes it compromises the result by including a suboptimal angiographic projection. And second, another technical reason is that so most cases you will have eccentric lesion. I think if you analyze IVUS, more than 80 or 90% are eccentric lesion. But it does not mean that the lumen is asymmetric. Actually, in many cases, you have eccentric lesion, but the lumen are symmetric. For example, in this case, you can see black glow on one side. It's eccentric lesion, but lumen is symmetric. So either you take from this projection or this projection, the lumen will be the same. So if you do a perfect correlation, then the 3D lumen will be also round. However, if your 3D reconstruction is less optimal, so misalignment there, then you can see that the circular lumen will become elliptical. So actually, this is a subtle technical problem. Not many people are aware of that. If you do 3D, it's not always better because sometimes you have imperfect correlation. Then you will have your model less accurate, so you compromise your result. And this is another explanation. So we further validate this single view in a larger population in the flavor study population. So in a blind analysis with Professor Koo, we analyzed 877 vessels, as you can see. Even retrospective analysis feasibility can be 95.4% because a single view is needed. And diagnostic accuracy was 90% in this study cohort. And in the same population, we analyzed the post-PCI mu-FFR because single view is needed. So we were able to analyze most of the post-PCI angiogram and all the correlates with a 2-year target vessel failure. So some of them from the FR guidance group and some of them from the IVUS guidance group. And this is main result showing that actually lower the mu-FFR will have a more event rate. So consistently demonstrated here. And the event rate actually diverse after 1 year. So within first year that the post-PCI physiology cannot differentiate them. But after 1 year, you can see the lower the mu-FFR, the higher event rate after 2 years. This similar result has been demonstrated in the FORZA sub-study published in Circuit Intervention last year. As you can see, the mu-FFR clearly predict the long-term outcome, 3-year target vessel failure. And how to make optimal post-PCI physiology. This has been demonstrated in the paper published last year called the virtual standing or PCI planning, especially for tandem lesion. You have 2 lesions here, so using the software you can predict if you stand this lesion, the mu-FFR will increase from 74 to 0.95. If you stand the distal lesion, you only slightly increase. So using this one, you can see in the least randomized trial, mu-FFR guided is better than angio guided in achieving the optimal post-PCI physiology. And similar has been demonstrated in the ARCHIVAS 2 study. The mu-FFR is comparable to microcatheter derived FFR in obtaining the optimal post-PCI physiology. So how does that reacted in the event in the trial? The flavor study that was published last month clearly demonstrated that this technology can change the decision. So the flavor 2 study is to investigate IVUS guided and the mu-FFR or angio-FFR guided group not only using for decision making, but also for PCR optimization. So it defined the criteria as here, post-PCR mu-FR less than 0.88 or the post-PCR delta mu-FR less than 0.5. And the result shows that the mu-FR is inferior to IVUS for PCR guidance in 1 year. As you can see, 80% were guided by the second generation single view mu-FR. And the event rate actually is lower than the first generation, clearly indicate that the more automatic solution would be better in terms of result. So this is summarized many other studies. Some of them have published and some of them are ongoing in the Angio-guided PCI RCT study. The similar technology has been extended to CT. Now it can be analyzed on-site automatically with the CT mu-FR. And we demonstrate that using it on-site in the hospital, it can, if you have good CT acquisition, the accuracy can be comparable to angio-based FFR. And this is another study in collaboration with Johns Hopkins Hospital showing that the CT with CT mu-FR is comparable to the invasive FFR with suspect in terms of prognosis. And similar has been extended to the OCT. Now we can use OCT IVUS calculate OFR, and we can also combine them because some of them, the intracoronary imaging is not enough to cover the entire lens. So we use the OCT for some of the segment, and the other one use angio, and combine them together. We saw that actually this combination would slightly improve compared to the angio-based mu-FR. And we analyze further, actually, the improvement is in those cases with suboptimal angiographic image quality. So if you have good angiographic image quality, angio-based mu-FR is good enough, but if not, then including intracoronary imaging would further improve the computation. So ladies and gentlemen, QFR or mu-FR allows fast computation of FFR and so good diagnostic concordance with wire-based FFR. Artificial intelligence significantly improved the level of the automation of FFR computation, facilitating reliable and fast analysis of mu-FR in routine clinical practice. mu-FR guide comprehensive PCR strategy encompassing revascularization decision-making stand optimization was non-inferior to IVUS guidance. On-site computation of CT mu-FR from CCTA image is feasible and is good prognostic value in patients with suspected CAD. In vessel with suboptimal angiographic image quality, fusion of OCT and angiography improves the diagnostic accuracy of mu-FR. And thank you again for your attention.
Thank you, Dr. Shengxian Tu, and it's very interesting to see all these endeavors to derive physiologic indicators from computational analysis. That also refers to Dr. Matsuo. There are two papers which we should keep in mind, in my view, in this respect. In all studies where one particular algorithm is compared in a specific group of patients, there is a rather good sensitivity and specificity, a rather good accuracy. There was one paper from the group of Patrick Sarhuizen in Galway not so long ago, where in an arbitrary group of patients, all these different algorithms were compared with truly measured FFR, and there the performance was, let's say, disappointing. The other paper which is important in this respect is the Phase 3 study, which would have been presented today here by Dr. Holm, but he couldn't make it to be here, so we have to leave that out. But in the Phase 3 study, of course, it was shown quite clearly that QFFR was still inferior to actually measured FFR. Is there somebody in the audience or in the panel who want to...
I have one question, Dr. Matsuo. So what type region has discrepancy between Angio-FFR and wire-FFR, or any region that has no discrepancy?
No, we have. For example, I believe that for the myocardium perfused by the vessel is really very important. For the lesions with the myocardial infarction or microvascular dysfunction, there's some kind of the discrepancy between the functional coronary angiography and the real FFR measurement. So it's however, it's there are no case which is completely different. I mean, majority of the cases we can measure by the functional coronary angiography. Right. And some limitations of the functional coronary angiography is anatomically it is very difficult to measure this technology, ostial region. This is one of the limitations of the case. Okay.
Thank you.
Carlos, when you perform such a PPG procedure, you do it in combination with FFR. How do you do it in clinical practice? It is just a manual pullback maneuver. Does it take much time, or is it done very rapidly?
Yeah, so the instructions is you start with an FFR measurement. When you reach a stable hyperemia, you start, I'm going to describe the process, Nico. So you are in the distal part of the vessel, then you start recording the pressure, and then you start pulling back the wire. What is important is not to stop. You have to pull back continuously, steady at the same speed, not too fast, not too slow. And then when the sensor reaches the guide, you just click stop, and then you have a beautiful pullback. You click on the PPG and comes on the screen. So it's part of the FFR measurement because you have to do a pullback to check the drift anyway. You are just taking information that you were given sometimes for granted as part of the interpretation for the measurement. So it takes, I would say, if you do it very fast, 20 seconds. If you are more calm and relaxed, 40 seconds. But that's the other time for CAT.
And the further analysis is automatically on the screen of the Abbott Coroventis
yeah, it's one
interplay.
Click. Once you have that, you just click on the PPG button, and then you get it in front of you. So you get the PPG, the new platform. You will have also, what is exciting about this is that you can now predict what's going to happen. So we're now busy with this prediction element of the curve that based on what you are treating, you can know what's going to be the flow at the end of the procedure. And that's kind of what I was referring to, the new use of physiology, which I think it's quite important to have a tool that can help you predict the outcome before you intervene the vessel. So that's a bit.
Okay, thank you. Dr. Tu, you discussed both Angio-FFR and you also discussed FFR by CT, isn't it? For my feeling, there is a kind of fundamental difference because FFR by CT, which is not optimal either, is truly non-invasive. So I think there's a fundamental advantage, and I can expect that you have lesser demands on such a methodology than on an invasive methodology. If you are in the CAT lab and you like to measure FFR, you can also do it by wire. Of course, you are saving the wire now, but you are already in the CAT lab. If you have an FFR CT, you are still far away from the CAT lab.
A good comment. I think that's the way believe that this tool is not one taking over the other. It's more like complementary because for patient with acute patient, you don't have a CT, so you just go to the CAT lab. And in such case, many patients, the culprit vessel will be treated, but there's still unculprit vessel. We still need a physiology assessment. So in this case, angio-based FFR could be an alternative. And second, I think the CT, the scanning, still currently the quality is still verified among center. Maybe in the future, photon counting CT would be changing this game. But at this moment, still angio has a better resolution. And some of the case that indeed invasive angio would be better if you have a better acquisition in angio. Yeah.
And I presume that the computational methods have a lot of similarities.
I agree, yes.
Is there somebody else here in the audience who want to say something? Eveline, maybe you want to comment, because if I look at the pictures, I also see something about echoes, Ivers, in it.
No, I wanted to ask you a question, because having you here as a chairman, of course it seems way faster, simpler, and just more pleasant to do a non-hyperemic functional measurement. We know, you expressed also concerns from a fundamental point of view. So let me ask this question. Do you see a sweet spot for non-hyperemic FFR measurements?
Well, if I have an old lady in a distal circumflex with diffuse disease, then it doesn't matter so much. But the problem is that the people where we are really interested in physiology are young persons with a large territory to be perfused by the vessel, with an intermediate lesion, 50 to 70%. And these are the patients in whom it really matters. If you have a false negative measurement over there, the patient might have an infarction or die. So I would be very cautious to trust upon the non-hyperemic measurements. That's my personal opinion. But I think that is also supported by the J-Pride. If you look at the conclusion of this J-Pride, it says, if there is discordancy, then you should trust upon FFR. But of course, you only know that there is discordancy if you have measured them both. So you can better say then, you should trust on FFR. That's a simple statement. And that's less or more recognized in the American guidelines, but not in the European guidelines. Jung-Min, you returned, and you have the last word.
Not last one, just one question to the Dr. Tu. So I think it's a silly question, but I think nowadays we are many non-invasive or non-wire-based physiology evaluation. So I think better quality coronary angiogram is way more important than before. So you are an engineer, so we spend more radiation, we spend more contrast compared with the CT. Coronary angiogram, we spend more radiation and more contrast. Then why quality of coronary angiogram sometimes poor than CT? So how to take, is there any good advanced technology to improve the quality of angiography nowadays?
Thanks for the question. Yeah, definitely a very good question. Not many people are aware that actually the technology itself is not the only issue. The other issue is the image acquisition or the image quality. So we try to have a standard operation procedure to ask the operator to make the image quality optimal before using this technology. And some of the data is actually encouraging because in some center where the operator are using it routinely and they start to think about how to make the good image quality in order to use this technology. So we can see the accuracy really increase over this time. So at least in China, quite some center they're using it routinely. A lot of QFR or MUFR analysis there. And I can see that if the operator passed the learning curve phase, then most of the quality is okay. So they know how to make good angiogram. It's just that if you do retrospective study, and people are not have this mind when they make the angio acquisition, that's the problem for the accuracy of computational physiology.
Okay, thank you very much. I would like to finish this session thanks to the audience, thanks to the speakers and to the panel. I think it was a very interesting session. Thank you very much. Have a nice evening.